Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the cardiology, that is the dilated cardiomyopathy. So, among the various forms of cardiomyopathies, like we have dilated cardiomyopathy, restrictive cardiomyopathy and as well as the hypertrophic cardiomyopathy. So, out of these three forms of cardiomyopathies, the most common form of cardiomyopathy is the dilated cardiomyopathy, right? Now, in these patients with the dilated cardiomyopathy, the individuals will have or the individuals will develop the heart failure. So, ultimately, all these cardiomyopathies, they progress, right? They progress to the development of the heart failure, right? So, you take this heart failure also. How is this heart failure being classified? Heart failure is being classified again as the heart failure with preserved ejection fraction and a heart failure with reduced ejection fraction. So, this dilated cardiomyopathy is the one which will cause the heart failure with reduced ejection fraction. Right, it is the one which will cause the heart failure with reduced ejection fraction. That is what you will observe in dilated cardiomyopathy. So, when you are using the word heart failure with reduced ejection fraction, and how much should be this ejection fraction? Ejection fraction should be less than or equal to 40%. Right, ejection fraction should be less than or equal to 40%. So, you see this question now. Contractile dysfunction is the dominant feature of which of the following types of cardiomyopathy? Dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, infiltrative cardiomyopathy. So, it is in dilated cardiomyopathy where the individual will have the systolic dysfunction. Right, where the individual will develop systolic dysfunction. That is what you will observe in patients with the dilated cardiomyopathy. And in these individuals with dilated cardiomyopathy, you will have heart failure with reduced ejection fraction. Alright. Now, in these patients, you have to understand that the contractile capacity of the heart is reduced, but relaxation will be normal. So, there is no diastolic dysfunction in patients with dilated cardiomyopathy. Right, it is only the systolic dysfunction. Whereas, you take other forms of cardiomyopathy. So, cardiomyopathies, we classify that into two types. One, the cardiomyopathy with systolic dysfunction, and other form of cardiomyopathy, that is diastolic dysfunction. And the one which will cause systolic dysfunction will be dilated cardiomyopathy, and the cardiomyopathies with diastolic dysfunction, that will be restrictive cardiomyopathy, and as well as the hypertrophic cardiomyopathy. Right, restrictive cardiomyopathy and as well as the hypertrophic cardiomyopathy. Right, so these are the conditions where you will have heart failure with preserved ejection fraction. Right, so heart failure with reduced ejection fraction, that is dilated cardiomyopathy, and heart failure with preserved ejection fraction, that will be restrictive cardiomyopathy and as well as the hypertrophic cardiomyopathy. Now, let me discuss the etiologies regarding the dilated cardiomyopathy. So, if you see the question, what is the most common toxin causing dilated cardiomyopathy? Alcohol, chemotherapeutic agents, heavy metals, occupational exposure. Let me tell you, the most common toxin that will cause the dilated cardiomyopathy will be the alcohol. Then followed by that, you also have some chemotherapeutic agents which will cause the dilated cardiomyopathy. So, you see this question here, 44-year-old female patient, known case of malignancy of the breast, is on chemotherapy since 2 years. She is HER2 receptor positive. She presented to the emergency department with history of dyspnea. She takes the drug subcutaneously, and which particular drug is she taking which is causing the dyspnea? The options are adriamycin, trastuzumab, doxorubicin, cyclophosphamide. Let me tell you, Actually, all these drugs are the anti-neoplastic drugs. But all these drugs will cause the dilated cardiomyopathy, which will make the individual to develop dyspnea. Right, which will make the individual to develop dyspnea. But out of all these, the drug which is given subcutaneously is trastuzumab. Right, out of all these drugs, the one which is given subcutaneously is your trastuzumab. Right, that is the one which is responsible for the development of your dilated cardiomyopathy. Now, followed by that, we have many other etiologies which are causing dilated cardiomyopathy. Like for example, what are the inflammatory causes for dilated cardiomyopathy? Let me tell you, we have autoimmune diseases. Right, we have autoimmune diseases causing dilated cardiomyopathy, and these autoimmune diseases include number 1, systemic lupus erythematosus. Then so these autoimmune diseases include systemic lupus erythematosus and then systemic sclerosis. Right, and another important disorder is dermatomyositis. Okay, so these are the autoimmune disorders which are the inflammatory causes of the dilated cardiomyopathies. And then followed by that, we also have some post-infective causes. Right, we also have some post-infective causes which will cause the dilated cardiomyopathy. Then, after having discussed about the inflammatory causes for dilated cardiomyopathy, you need to know what are the nutritional causes for dilated cardiomyopathy. See, nutritional causes for dilated cardiomyopathy include number 1, B1 deficiency, that is thiamine deficiency. Right, and number 2, selenium deficiency. Right, thiamine deficiency and then selenium deficiency. So these are the nutritional causes of the dilated cardiomyopathy. Then you also need to know what are the endocrine causes for dilated cardiomyopathy. Endocrine causes for dilated cardiomyopathy include diabetes mellitus, then followed by that the thyrotoxicosis, right, then followed by that hypothyroidism. Right, so these are the endocrine causes of dilated cardiomyopathy. Right, now after having discussed about the inflammatory causes, nutritional causes and endocrine causes, you need to know what are the hematological causes of dilated cardiomyopathy. The hematological causes for dilated cardiomyopathy include number 1, sickle cell anemia. Right, so this will be the hematological causes for dilated cardiomyopathy. Now, followed by that, we also have toxins. Toxins are those, that is the alcohol. This already I have said you, that will be the most common toxin. And apart from that, we have many chemotherapeutic drugs which will cause the dilated cardiomyopathy. And these chemotherapeutic drugs include adriamycin, right? Then followed by that, we have trastuzumab. Then next we have cyclophosphamide. And lastly we have cocaine. Okay, so these are the toxins, they are responsible for the development of dilated cardiomyopathy. Right, and among all these toxins, alcohol is the most common toxin. Then we also have some infiltrative disorders or infiltrative causes of dilated cardiomyopathy. The infiltrative causes of the dilated cardiomyopathy include hemochromatosis. Right, so what is this hemochromatosis? It is the disorder where there is excessive infiltration of iron into the myocardium. Right? Excessive infiltration of iron into the myocardium, and that will be responsible for the development of dilated cardiomyopathy. Then followed by that, you also need to know what are the neuromuscular causes, which we will be discussing now. So, you see this question, a 24-year male patient presented with history of ataxia of gait, and Romberg sign is positive, and there is also dysmetria. He also complains of dyspnea on exertion, and echocardiography showed ejection fraction of 30% with dilated chambers. What would be the etiology? Cerebellar ataxia, Friedreich's ataxia, subacute combined degeneration of the spinal cord, selenium deficiency. So the answer in this question is the Friedreich's ataxia. Right. So what is this particular Friedreich's ataxia? It is a disorder which is characterized by mutation of a gene, that is frataxin gene. And these patients with the Friedreich's ataxia, they also develop the dilated cardiomyopathy. And that is the reason why you have dyspnea on exertion, and that is the reason why these individuals will also have the presence of the dilated chambers. Now, you need to know what are all the neurological causes for the development of the dilated cardiomyopathy. Right? That includes number 1, muscular dystrophies. Right. Number 2, Friedreich's ataxia. Right. Number 3, myotonic dystrophy. Okay. So these are the neurological causes for the development of the dilated cardiomyopathy. Now, out of this, let me discuss few points about the Friedreich's ataxia. See, these patients with Friedreich's ataxia, the initial symptom will be ataxia. Right? The initial symptom will be ataxia, and they'll have all the features of cerebellar involvement. Right? All the features of cerebellar involvement, that is, they'll have wide based gait. Right? And Romberg sign will be positive. There will be also dysarthria, where there is difficulty in articulation of the speech. There will be also dysmetria, and then nystagmus. So these will be the features of the Friedreich's ataxia. Then you see the next question here. Keshan disease is associated with a virus causing dilated cardiomyopathy. And what is that particular virus? HIV, Coxsackie virus, Epstein-Barr virus, cytomegalovirus. So please remember, the answer is the Coxsackie virus. Okay. And what is this particular Keshan disease? That is selenium deficiency. Okay. Selenium deficiency in combination with Coxsackie virus infection. Right? Selenium deficiency in combination with Coxsackie virus infection. This can lead to the development of a potentially fatal condition that is called Keshan disease. Right? That is called Keshan disease. And this selenium deficiency also contributes to Cashin-Beck disease. Selenium deficiency also causes Cashin-Beck disease. Now, what is this particular Cashin-Beck disease? Cashin-Beck disease, along with selenium deficiency, you also have, right, along with selenium deficiency, you also have iodine deficiency as well. Right? And what will be the primary symptom of this Keshan disease? The primary symptom of Keshan disease is myocardial necrosis. right, myocardial necrosis. And because of myocardial necrosis, that will lead to weakening of the heart. Right, that will lead to weakening of the heart. Okay, whereas you take in case of Caschen-Beck disease. Caschen-Beck disease results in atrophy, degeneration and necrosis of the cartilage tissue. So this will result in atrophy, degeneration and necrosis of cartilage tissue. So that is about the Caschen-Beck disease. Okay, and you take in case of Caschen disease. Caschen disease also makes the body more susceptible to illness, which is caused by other nutritional, biochemical or infectious diseases. So that is about your Caschen disease. So what is Caschen disease? It is the disorder where there is selenium deficiency in combination with Coxsackie virus. And selenium deficiency is the one which will cause the myocardial necrosis, where the individual will develop the dilated cardiomyopathy, right? You see the next question. A 44-year male chronic alcoholic presents with the shortness of breath and leg swelling and numbness of the hands and feet. There is also confusion, trouble moving the legs and pain. On examination, there is raised JVP and there is presence of the pedal edema. 2D echo, it is diagnostic of dilated cardiomyopathy. How to diagnose the etiological agent? Very important clue here is the chronic alcoholic. And along with that, the individual also has difficulty in breathing and as well as leg swelling and numbness of the hands and feet. So in patients with chronic alcoholics, you need to know what all the deficiencies the individual can develop. You see the options. Activity of enzyme transketolase in the erythrocytes, Schilling test, selenium levels, HbA1c levels. So let me tell you, in patients with alcoholics, the agent which will be responsible for the development of dilated cardiomyopathy is due to impairment in the activity of enzyme transketolase in erythrocytes. Right, impairment in the activity of the enzyme transketolase in the erythrocytes. Okay, so that is about like what happens in patients with the dilated cardiomyopathy. Next, coming to the clinical features in these patients with the dilated cardiomyopathy. So the clinical features, if you observe, these individuals, they have the symptoms of progressive left-sided and later there will be also right-sided heart failure. So these individuals, they have symptoms of left-sided, later there will be features of right-sided heart failure. Okay, so that is about the clinical manifestation. And what will be the features of left-sided heart failure? They will have paroxysmal nocturnal dyspnea, they will have orthopnea, and they will have dyspnea on exertion, and they will also have fatigue. That will be left-sided failure manifestation. And what will be right-sided failure manifestation? There will be raised JVP, there will be tender hepatomegaly, there will be presence of pedal edema, and then ascites. These will be the manifestation of right-sided heart failure. Then followed by that, in these patients with the dilated cardiomyopathy, sudden death is common. Right, sudden death is common. And what is the reason for sudden death in these patients with the dilated cardiomyopathy? That is due to arrhythmias. Right, that is due to arrhythmias. Now, apart from that, in these individuals, how will be the chambers? They have the dilated chambers. And these dilated chambers, what will happen to the systolic function of these dilated chambers? There is systolic dysfunction. Now, because there is systolic dysfunction, what will happen? You see here. So, because of the systolic dysfunction, there can be stasis of the blood. And that will result in the thrombus formation. Right, that will result in the thrombus formation. And this thrombus, it can rupture and it will shower in the form of the emboli. Right, this thrombus will rupture and will shower in the form of the emboli. So, that will be the features of the dilated cardiomyopathy. So, they also have the features of systemic embolization. Right, they also will have the features of the systemic embolization. So, you see this is a two-dimensional echocardiography of a patient with the dilated cardiomyopathy. You can observe. So, all the chambers, they are dilated. Right, all the chambers, they are dilated in these patients with the dilated cardiomyopathy. Now, if you observe the signs in patients with the dilated cardiomyopathy, so because it is the disorder characterized by systolic dysfunction, so there will be reduced systolic blood pressure or low systolic blood pressure, and thereby what will happen to your pulse pressure? They will have narrow pulse pressure, right? And what will happen to the JVP? The jugular venous pressure, it is raised. That is the feature of your right-sided heart failure. And there will be also cardiomegaly. And these patients, they have the signs of the heart failure. Right, they have the signs of the heart failure. And what will be that? Presence of third heart sound and as well as the fourth heart sound. And not only that, because the chambers are abnormally dilated, the valves, they are stretched apart. So thereby, these individuals, they'll have auscultatory finding, that is functional MR and TR. Right, functional mitral regurgitation or the tricuspid regurgitation. And these individuals, even the arrhythmias, they are very common. So this will be the signs that you will observe in patients with the dilated cardiomyopathy. And if you see the investigations in these individuals, if you do a chest X-ray will show you the presence of the cardiomegaly, that is left ventricular enlargement will be there, or there can be generalized cardiomegaly. Okay. So these in chest X-ray will show you the presence of the cardiomegaly. And not only that, these individuals, they also have the evidence of the pulmonary venous hypertension. Right, they also have the features of pulmonary venous hypertension. So what will be the features of pulmonary venous hypertension? That includes distended or dilated upper lobe veins. Okay, so that will be the evidence of the pulmonary venous hypertension. And subsequently, because of raised pulmonary capillary wedge pressure, there will be also interstitial edema, or there will be development of the alveolar edema. right? So there is development of interstitial edema and subsequently there will be development of the alveolar edema. Now you take the chest x-ray in these individuals, so you can observe that here. Presence of the cardiomegaly. Now you take the ECG in these individuals. ECG, right, you don't have a specific changes, they have non-specific STT changes. Right, they have non-specific STT changes, and these changes, apart from that, these individuals, they also have sinus tachycardia. There can be also development of the atrial fibrillation. So in atrial fibrillation, what does the ECG shows? The ECG shows variable RR interval, and you don't have a P wave, you have the presence of the fibrillatory waves. And you also have the features of the atrial and as well as the ventricular enlargement. Okay, so this will be the ECG in patients with the dilated cardiomyopathy. And what is the investigation that will confirm the diagnosis? It is the 2D echo that will, right, that will confirm the diagnosis. And what does this echocardiography reveals? It reveals dilated right ventricle or the left ventricle. And apart from that, the 2D echo also will show you that there is poor global contractile function. Right? The individual will have poor global contractile function. That means these individuals, they'll have heart failure with reduced ejection fraction, where the ejection fraction will be less than 40%. Right? Where the ejection fraction will be less than 40%. So that will be the echocardiographic manifestations in these individuals. Then you take the cardiac biomarkers. The cardiac biomarkers, they are elevated. But which particular cardiac biomarker is elevated? That is brain natriuretic peptide is elevated. And why is that? Because these individuals, they have the development of the dilated ventricles, and because of the distended ventricles, they will release the brain natriuretic peptide into the circulation. Then next important investigation is the angiography. Angiography should be performed in older patients to exclude coronary artery disease. Right? Should be done in older individuals with dilated cardiomyopathy to exclude the coronary artery disease. Right? And other investigations like the endomyocardial biopsy. This is not routinely done. This is mainly used to rule out a treatable cause. But in dilated cardiomyopathy, endomyocardial biopsy, this is not routinely being done. Now, so after having discussed about the investigations, so what is the investigation of choice, or what is that which will confirm the diagnosis? That will be your 2D echo. Now let me discuss the treatment in these individuals. Which of the following drugs is not given in dilated cardiomyopathy? Beta blockers, calcium channel blockers, spironolactone, AC inhibitors. So please remember, in patients with dilated cardiomyopathy, it is the heart failure with reduced ejection fraction. And in individuals with reduced ejection fraction, you should not give the calcium channel blockers. Right? You should not give calcium channel blockers. Right? In fact, you take the beta blockers. Beta blockers, they are the first line drugs. Okay? But these beta blockers or AC inhibitors or spironolactone, all of these drugs have to be added right, beta blockers or AC inhibitors or spironolactone. These drugs have to be added only when the blood pressure is above, when the systolic blood pressure is above 90 millimeters of mercury. That is the point when you need to add these beta blockers or ACE inhibitors or spironolactone. And among the beta blockers, you need to add the cardioselective beta blockers. And what are those first line beta blockers? That includes bisoprolol, then metoprolol, then we have carvedilol, right? Then we have carvedilol. So these are the beta blockers, that is bisoprolol, metoprolol, and then the carvedilol. Okay, so these have been shown to reduce the mortality in patients with dilated cardiomyopathy, right? So they will improve the survival of the individual. So these ACE inhibitors, they will lead to 35% reduction in, right, 35% reduction in endpoint mortality in heart failure patients. So basically, these are the drugs that will prevent cardiac remodeling, right? These are the drugs that will prevent the cardiac remodeling. And you take this spironolactone, which is an aldosterone antagonist. This is also associated with reduction in mortality in all stages of symptomatic dilated cardiomyopathy, right? Now, so in detail, if you see the treatment, first and foremost, avoid strenuous exercise, right? Avoid strenuous exercise, and you have to give the drugs for the treatment of the heart failure. And that particular drugs that should be given for the treatment of the heart failure include diuretics, ACE inhibitors, and then beta blockers. And these diuretics include mainly the spironolactone. And you can also give additional vasodilators, right? These additional vasodilators, why are they given? These additional vasodilators, they are given mainly to reduce the afterload on the heart. And they include nitrates and as well as hydralazine. So these are the vasodilators that can be given that will reduce the afterload on the heart. And you take this aldosterone antagonists and all, what is the purpose of giving them? That is mainly to prevent the cardiac remodeling and thereby reducing the mortality. Now, in severe cases, right, you know, like where the blood pressure is on the lower side, you also need to give the inotropes, okay? So, in severe cases, not responding to other medications, you need to give the inotropic agents, and these inotropic agents include digoxin, dopamine, and as well as the dobutamine. These are the inotropes that have to be given in severe cases who are not responding to other medicines. And the drugs to prevent the embolism, that includes the anticoagulants. Anticoagulants should be given to prevent the embolism, because in these patients with the dilated cardiomyopathy where there is systolic dysfunction, there will be stasis of the blood, there will be thrombus formation, and there can be embolization. So in order to prevent that thrombus formation and embolization, anticoagulation should be given to prevent the embolization, right? Then, so now let me discuss the interventions and as well as devices for the dilated cardiomyopathy. So you need to know what are the devices which are required for the treatment of the dilated cardiomyopathy. That includes, number one, these patients, they may require the implantation of implantable cardioverter defibrillator. Now, what is the purpose of this implantable cardioverter defibrillator. The purpose of implantable cardioverter defibrillator is to prevent the development of the arrhythmias to prevent the development of arrhythmias and to prevent the sudden cardiac death, thereby to prevent the sudden cardiac death. So this is one of the device which is required in patients with the dilated cardiomyopathy. And the another important device is these patients at certain point of time they may also require the permanent pacemaker. This permanent pacemaker requirement will be there only when there is degeneration of the conducting system of the heart. Like for example, you take some infiltrative disorders or you take some autoimmune disorders. They can cause the impairment of the conducting system of the heart. At one point of time, they require the permanent pacemaker. Okay. Next, another very important intervention which is required in the treatment of this dilated cardiomyopathy will be LVAD. This LVAD, it stands for left ventricular assist devices. Left ventricular assist devices. Okay, so this is about your LVAD. And finally, at one point of time, they also require cardiac transplantation, where I will discuss. But before that, you see one important question. Indication of this device in dilated cardiomyopathy with left bundle branch block. QRS duration more than 110 milliseconds, QRS duration more than 100 milliseconds, QRS duration more than 150 milliseconds, QRS duration more than 120 milliseconds. Now, first of all, you need to identify what is this device that is placed in patients with the dilated cardiomyopathy. See, you have a PG, that is pulse generator, and you have three leads. One lead is in the right atrium, the other lead is in the right ventricle, the other lead is in the lateral wall of the left ventricle. So, what is this device with pulse generator having three leads? That is nothing but your cardiac resynchronization therapy. Right, cardiac resynchronization therapy. Now, what does this cardiac resynchronization therapy do? The word itself tells you cardiac resynchronization. Actually, in dilated cardiomyopathy, what will happen is the right and left chambers are abnormally dilated, and the synchrony between the two ventricular contractions is gone. Right ventricle and left ventricle, they don't contract simultaneously, which has to occur in a normal individual. So, in order to improve the synchrony between right and as well as left ventricle, we use this cardiac resynchronization therapy. And in patients with left bundle branch block, with a QRS duration of more than 150 milliseconds, this cardiac resynchronization therapy has to be used. Okay, so let me discuss in detail about the indication of the CRT. So this is the device used in patients with the dilated cardiomyopathy. And in which group of patients of dilated cardiomyopathy we use this? Patients with continued symptoms of the heart failure. Right, patients with continued symptoms of heart failure and reduced ejection fraction of less than 35% or less, you should use this cardiac resynchronization therapy. Okay, and continued symptoms in the sense, in spite of medical management, the individual is symptomatic and the QRS duration is more than 150 milliseconds. That is the point where you have to use this cardiac resynchronization therapy, right? And what should be the ECG criteria? That should be individual having the QRS duration more than 150 milliseconds in that individuals you need to use the cardiac resynchronization therapy, right? And patients with advanced refractory symptoms, they should be referred for consideration of the heart transplant or the LV assist device therapy. So that is about the treatment of the dilated cardiomyopathy. So actually, what will be the first line treatment? The medical management that includes beta blockers, ACE inhibitors, and as well as the aldosterone antagonists. But in a recent times, the medical management, we also have some new molecules. So in patients with dilated cardiomyopathy with reduced ejection fraction, the new molecule that can be tried to improve the ejection fraction is valsartan plus sacubitril, right? Valsartan plus sacubitril. So this is a new molecule which we call it as ARNI, that is angiotensin receptor blocker neprilysin inhibitor, right? Angiotensin receptor blocker neprilysin inhibitor. So your valsartan, it is an angiotensin receptor blocker, whereas sacubitril, it is a neprilysin inhibitor. So this combination, if you give, it can improve the ejection fraction within the individual. So this is about the medical management, and in those individuals who are refractory, we have to put that particular patient on the cardiac resynchronization therapy or left ventricular assist device, or ultimately these patients, they require the cardiac transplantation. Now, see, what is the most common toxin which will be causing dilated cardiomyopathy? That is alcohol. So this alcoholic cardiomyopathy develops in individuals who consume large quantities of alcohol for several days. Right, who consume large quantities of alcohol for several days. And what should be that large quantity? That should be more than 90 grams per day. Right, that should be more than 90 grams per day of alcohol if it is taken over several years. That is the group of individuals who develop this dilated cardiomyopathy. And regarding this alcohol, you also need to remember one important syndrome, that is holiday heart syndrome. Holiday heart syndrome, it is another form of the alcoholic cardiotoxicity. Right, it is another form of the alcoholic cardiotoxicity. It is not cardiomyopathy. Right, it is a form of the alcoholic cardiotoxicity, and this appears after drinking a binge. Right, after consuming a large quantity of alcohol, the individual can develop this alcoholic cardiotoxicity, which is nothing but your holiday heart syndrome. See, this particular, why is this terminology holiday heart syndrome being used? Because usually it is the weekends where the individual will try to consume a large quantity of alcohol, right, during the holidays. So that is the reason why it is called holiday heart syndrome. Now, what will be the manifestations of this holiday heart syndrome? The presentation is with recurrent supraventricular and ventricular arrhythmias. Okay, so presentation is with recurrent supraventricular and ventricular arrhythmias. Now, what are those supraventricular arrhythmias? Very common. That will be in the form of, right, that will be in the form of atrial fibrillation. So these will be the features of the holiday heart syndrome. So after having discussed about the alcoholic cardiomyopathy, let me discuss another very important form of dilated cardiomyopathy which is seen during pregnancy or immediately in the postpartum period. That is called peripartum cardiomyopathy. Let me tell you, even this peripartum cardiomyopathy, this is also a form of dilated cardiomyopathy. So, after having discussed about the dilated cardiomyopathy, let me take up the discussion of the very important form of cardiomyopathy, that is peripartum cardiomyopathy. So, this peripartum cardiomyopathy, this is also a dilated cardiomyopathy. Now, what exactly is the definition of this peripartum cardiomyopathy? Let me discuss. So, in these individuals with peripartum cardiomyopathy, they have the features of the dilated cardiomyopathy, and that features of dilated cardiomyopathy, they develop during the last month of pregnancy or within 6 months of delivery. So, they develop during during last month of pregnancy, or within or within 6 months of delivery. Okay, so that is what is your peripartum cardiomyopathy. Now, another important point is, for the development of this dilated cardiomyopathy, there should be absence of a demonstrable cause for cardiac failure. That means there should not be any demonstrable cause for the development of the cardiac failure. That is another very important point. Absence of demonstrable cause for the development of the heart failure. Okay, so this is what is the definition of the peripartum cardiomyopathy. Next, now what is the hypothesis for the development of dilated cardiomyopathy? So the hypothesis is vasculohormonal hypothesis, right? And this vasculohormonal hypothesis, it requires the two events that has to be occurred. What are those two events? Let me tell you what are those two events that will predispose, that is responsible for the development of the dilated cardiomyopathy in the last month of pregnancy or 6 months postpartum. First one is the genetic. The first one is genetic. Now, what is this the genetic factor? That is reduction in STAT3 transcription factor. Reduction in STAT3 transcription factor. Now what happens? So if there is reduction of STAT3 transcription factor, what will be the responsible event? Because of this, there is myocardial apoptosis. There will be increased myocardial apoptosis, and that will be responsible for the development of the dilated cardiomyopathy. So this is one of the hypotheses among the two, that is reduction in STAT3 transcription factor. So once there is reduction in STAT3 transcription factor, that will result in the cleavage of the prolactin, and this prolactin is the hormone which is being released from the anterior pituitary. And because of the cleavage of prolactin, this results in increase in the levels of microRNA, and this increased microRNA will cause increase in the myocardial apoptosis. That will be the first event. Then, and you take the second event. The second event is from the placenta. From the placenta, there is release of a substance called soluble tyrosine kinase. And this soluble tyrosine kinase, what it will do? it will block the vascular endothelial growth factor. Right, it will block vascular endothelial growth factor. So this will be responsible for the development of the dilated cardiomyopathy. So both these components, that is reduction in STAT3 transcription factor and as well as release of the tyrosine kinase from the placenta, both of these components may be necessary to effectively result in the development of the peripartum cardiomyopathy. Right? Now, what are the risk factors for the development of the peripartum cardiomyopathy? So, risk factors include, number one, it usually occurs in multiparous females after the age of 30 years. Right? Number one, it occurs in multiparous females. Right? It occurs in multiparous females after the age of 30 years. That is one of the risk factors, that is multiparous females. And what are the other risk factors? The other risk factors include the presence of the hypertension in the female and development of preeclampsia. Right? Development of preeclampsia and multiple twin gestations. Right? Multiple twin gestations. So these are the risk factors for the development of the peripartum cardiomyopathy. Next, another very important point, as already I have mentioned, there should be absence of demonstrable heart disease before the last month of the pregnancy. That means, what do you mean by the word absence of demonstrable heart disease? The same word I have said you in the beginning also in the definition. That means the female should not be having any history of coronary artery disease. The female should not be having any history of cardiomyopathies in the past. That is very important. If there is any past history of coronary artery disease or any past history of cardiomyopathy now landing up in dilated cardiomyopathy in pregnancy, then it is not called peripartum cardiomyopathy, right? And another important thing is there should be a documented systolic dysfunction. So ejection fraction should be around 35%. Right, there should be a documented systolic dysfunction. Okay, next, followed by that, how do you treat these patients with the dilated cardiomyopathy, which is nothing but peripartum cardiomyopathy? So the first line drugs will be the beta blockers. Beta blockers, they have been administered judiciously to these patients with at least anecdotal success. And what is that beta blocker that you have to administer? That particular beta blocker that you have to administer is sotalol. Right, that is sotalol. Sotalol, it is acceptable for ventricular or atrial arrhythmias. Right, what is the purpose of giving the sotalol is to decrease ventricular or right, to decrease ventricular or the atrial arrhythmias, right? So if other beta blockers are ineffective, then the ideal beta blocker that we can give is sotalol, that is acceptable for ventricular or atrial arrhythmias. Now, not only that, the other important drugs with minimal risk to fetus includes the diuretics. Diuretics, they will reduce the pulmonary edema or the pedal edema in patients with the peripartum cardiomyopathy. Then the other group of drugs are the hydralazine and as well as the nitrates. So hydralazine and as well as nitrates, these are the drugs which will reduce the afterload. Right, these are the drugs which will reduce the afterload on the heart. So when these drugs reduce the afterload on the heart, that will improve the mortality. right, or that will reduce the mortality in individuals with the peripartum cardiomyopathy. Next, so this will be your medical management. But when the severity of the disease increases, right, in severe cases, transient use of the ECMO has been life-saving, right? And what is this particular ECMO? That is extracorporeal membrane oxygenation. This has been found to be life-saving in severe cases. And apart from that, we have another very important drug, that is bromocriptine, which is a prolactin release inhibitor, right? See, your cleaved prolactin fragment, actually what is happening, because of decrease in STAT3 transcription factor, there is release of cathepsin D. That cathepsin D will cause the cleavage of the prolactin, and that cleaved prolactin fragment is the one which is responsible for your apoptosis. Now, whenever you give bromocriptine, what does this bromocriptine do? Bromocriptine, it will inhibit the prolactin release. Right, it will inhibit the prolactin release, right? And please remember, once the prolactin release is inhibited, then the individual for the development of peripartum cardiomyopathy can be reduced. Okay, so once the prolactin release is inhibited, then the chance of peripartum cardiomyopathy will be reduced. Right, the chance of peripartum cardiomyopathy will be reduced. Okay, next, and another important point is bromocriptine treatment was associated with high rate of full left ventricular recovery. Okay, so this bromocriptine, it is also associated with left ventricular recovery. Right, it is also associated with full left ventricular recovery, and this bromocriptine will also reduce the morbidity and mortality. Right, reduces the morbidity and as well as mortality in patients with peripartum cardiomyopathy. So that is about your bromocriptine, right? So that is the advantage of bromocriptine in patients with the dilated cardiomyopathy, right? And what about the recurrences? Let me tell you, regarding this peripartum cardiomyopathy, recurrences in subsequent pregnancies, it is very common, right? Recurrences in subsequent pregnancies, it is common. And when do you feel that the recurrences are very common? That is when from the previous pregnancy, if the cardiac function has not completely recovered, right? If the cardiac function, if it has not completely recovered, and subsequent pregnancies are to be discouraged if the ejection fraction is less than 55%. So, in peripartum cardiomyopathy, what will be the ejection fraction? In peripartum cardiomyopathy, the ejection fraction will be around 35% or less than 35%. And if this ejection fraction has improved, right, if the ejection fraction has improved to more than 55%, then there is chance of you can encourage the subsequent pregnancies. But if the ejection fraction, right, if the ejection fraction, if it has not improved, right, if it has not improved to 55%, then subsequent pregnancies should not be planned. Subsequent pregnancies should be discouraged. That is very important point when you are giving the advice to your patient of peripartum cardiomyopathy. Now, finally, what is the criteria for peripartum cardiomyopathy? Criteria for peripartum cardiomyopathy is absence of demonstrable heart disease before the last month of pregnancy. Okay, absence of right, absence of demonstrable heart disease before last month of pregnancy. So this is one of the criteria. Second important criteria is there should be a documented systolic dysfunction. Right, there should be documented systolic dysfunction. And next important thing, pregnancy must be avoided right, pregnancy must be avoided if left ventricular ejection fraction is less than 40%. Okay, so that is about the criteria of the peripartum cardiomyopathy, right? Now, after having discussed about peripartum cardiomyopathy, we have one more variant of the cardiomyopathy, that is Takotsubo cardiomyopathy. Takotsubo cardiomyopathy, it is a type of dilated restrictive hypertrophic toxic cardiomyopathy. Let me tell you, Takotsubo cardiomyopathy, it is a type of the dilated cardiomyopathy, right? Okay, so let me just summarize about peripartum cardiomyopathy. So peripartum cardiomyopathy is the development of dilated cardiomyopathy in the last month of pregnancy or 6 months postpartum, and there should be absence of demonstrable cardiac disease before the last month of pregnancy, right? And there should be a documented systolic dysfunction, and ejection fraction should be around 35%. And what are the risk factors? Very commonly seen in multiparous females and the one with multiple twin gestations, and that too the age of the individual in age group of around 35 years, right? And the presence of preeclampsia is also one of the risk factors. And the treatment is, you need to give beta blockers, that is sotalol, and in severe cases ECMO has to be placed. And in order to reduce the mortality, you can give the diuretics, and you can give the you can give nitrates and as well as the hydralazine. So that is about your peripartum cardiomyopathy. Now coming to your Takotsubo cardiomyopathy, that is also a form of the dilated cardiomyopathy. Now this is your Takotsubo cardiomyopathy. So this Takotsubo cardiomyopathy, right, this Takotsubo cardiomyopathy, what are the other names of this Takotsubo cardiomyopathy? This is also called as apical ballooning syndrome. Right, it is also called as apical ballooning syndrome. And why is that? Because it is the apex of the heart which has been ballooned out, and that is the reason why it is called apical ballooning syndrome. Now, not only apical ballooning syndrome, and why is it called the Takotsubo? Let me explain you. Right, why is it called Takotsubo? Let me explain you. See, the apex of the heart which has been ballooned out, it is in a shape of an object which is required to catch the octopus in Japan. You see, this is an object which is required, which is used to catch the octopus, and similar to that shape, your apex of the heart is also ballooned out, and that is the reason why, and the name of this object is Takotsubo, and that is the reason why it is named as the Takotsubo cardiomyopathy, and it is mainly the apex of the heart which is ballooned out. That is the reason why it is called the apical ballooning syndrome. Now, we also have the other names for this Takotsubo cardiomyopathy. See, this is also called the stress cardiomyopathy. Why is it called stress cardiomyopathy? Because the etiology for the development of Takotsubo cardiomyopathy is extreme stress. That is the reason why it is called stress cardiomyopathy. And let me tell you, this apex which is ballooned out, right, the apex of the heart which is ballooned out, there is high chance that it can rupture. Right, there is high chance that it can rupture. So once it ruptures, the individual will land up in what is called as a broken heart, and that is the reason why it is called broken heart syndrome. right? That is the reason why it is called broken heart syndrome. So your Takotsubo cardiomyopathy, these are the following names. Number 1, stress cardiomyopathy. Number 2, apical ballooning syndrome. Number 3, it is also called the broken heart syndrome. So that is about the various names of Takotsubo cardiomyopathy. Now let me discuss the etiology. So if you see the etiology, just now we have discussed, it is the stress. The most common mechanism is stress-induced massive catecholamine release. Stress-induced massive catecholamine release. Okay, so that will be the etiology. And this massive catecholamine release will cause the stunning of the myocardium, right? So this leads to subsequent stunning of the myocardium. And when you take a biopsy, right, when you take a biopsy from this myocardium or the heart, biopsy of the myocardium reveals focal myocytolysis. Right, focal myocytolysis. And this focal myocytolysis, along with this, under the microscope you will observe there is infiltration of the inflammatory cells, and that will be mononuclear infiltrates. Right, that will be mononuclear infiltrates. And along with that, you will also observe, or you will also notice the presence of contraction band necrosis. Right, you will also observe, or you will also notice the presence of the contraction band necrosis. So this will be the biopsy picture, right? It will reveal focal myocytolysis with mononuclear infiltrates and contraction band necrosis. Then let me tell you, when you do a 2D echo in these patients with the Takotsubo cardiomyopathy, it will mimic the myocardial infarction. So why do you think that it will mimic the myocardial infarction? Because this stress-induced cardiomyopathy, it is an increasingly reported syndrome which is characterized by transient systolic dysfunction of the apex of the heart. So here there will be transient systolic dysfunction of the apex of the heart, right? And because there is systolic dysfunction of the apex of the heart, that means some segments of your left ventricle, they are akinetic or they are hypokinetic. Now because there is transient systolic dysfunction, or some segments are akinetic or hypokinetic, that will mimic the myocardial infarction. Next, then followed by that, what will be the clinical features in patients with the Takotsubo cardiomyopathy? First and foremost, there should be a history of emotionally or physically stressful event, right? So there should be history of emotionally or physically stressful event, right? So that is that is one of the very important thing in the history or clinical features in patients with the Takotsubo cardiomyopathy. And what will be the most common presenting symptom? The most common presenting symptom will be in the form of chest pain and dyspnea. Right, chest pain and dyspnea, this will be the most common presenting symptom. And apart from this, the individual will also present with palpitations, and there will be also nausea, vomiting, and there can be also syncopal attack and cardiogenic shock. So these are the clinical features that you will observe in patients with the Takotsubo cardiomyopathy. Now, because there is a systolic dysfunction, and because of the systolic dysfunction, what will happen to the cardiac output within the individual? The cardiac output within the individual will be reduced because of the systolic dysfunction. And because the cardiac output is reduced, these individuals, they will have hypotension. Right, so hypotension due to reduction in the stroke volume and subsequently reduction in the cardiac output. So this will be the features of the Takotsubo cardiomyopathy. So most common presenting symptom will be chest pain and dyspnea, and along with that they can also have palpitations because of the arrhythmias which are originating from your apex, and there can be also nausea, vomiting, syncopal attack and cardiogenic shock. Right, and because there is systolic dysfunction, the cardiac output within the individual is reduced, and because of which the individual can present with the hypotension. Next, coming to the investigations in these patients. Right, so if you see the investigations in these patients, ECG, right, ECG, it will show you the presence of the ST segment elevation. Right, ECG will show you the presence of the ST segment elevation, and there is apical ballooning, that is myocytolysis. So if you take the cardiac biomarkers, the cardiac troponins will be elevated. Right, cardiac troponin levels will be elevated. So this ST segment elevation and as well as troponin being elevated, this will mimic ST elevation MI. Right, this will mimic ST elevation MI. Right, and even if you do a 2D echo already I have mentioned. So if you see this 2D echo, the 2D echo shows the hypokinesia of the LV apex. Right, hypokinesia of the LV apex. But when you do a coronary angiogram, right, when you do a coronary angiogram, the coronary angiogram, it shows normal coronary vasculature. Right, normal coronary vasculature. So this will be the investigations in patients with the Takotsubo cardiomyopathy. Now, followed by that, let me also discuss the criteria. The same thing we will put in the criteria of Takotsubo cardiomyopathy. So, and the name of that particular criteria is the modified Mayo criteria for Takotsubo cardiomyopathy. Right, number 1, the 2D echo, it shows the transient hypokinesia or akinesia of left ventricle. right? Hypokinesia or akinesia of left ventricle. Number 2, when you do a coronary angiogram, it shows absence of any coronary artery occlusion by a thrombus. So there will be a normal coronary vasculature. Right, and the ECG, as I have already mentioned, there will be ST segment elevation, right, and the troponin I or troponin T should be elevated, then followed by that. Now, what was the etiology we have discussed? Extreme stress causing elevation of your catecholamine levels. Okay, so what is the another clinical condition where there is elevated catecholamine levels in the blood? That is pheochromocytoma. So there should be absence of pheochromocytoma. Right, there should be absence of pheochromocytoma or myocarditis within the individual. So according to the modified Mayo's criteria for Takotsubo, all 4 criteria should be there. Right, all these 1, 2, 3, 4. All these 4 criteria should be there to consider that the patient is suffering with the Takotsubo cardiomyopathy. Now, how do you treat these patients? Immediate therapy is similar to any acute MI. Most of these patients, they have to receive the aspirin, right, aspirin. Then the other important group of drugs that have to be given in these individuals is beta blockers and the AC inhibitors. Beta blockers and as well as AC inhibitors, they will reduce the cardiac workload. AC inhibitors, they will reduce the afterload on the heart, and beta blockers, they will reduce the heart rate and thereby they will reduce the cardiac workload. So these drugs have to be given until the LV fully recovers. Right, until the left ventricle fully recovers, you need to give these beta blockers and the AC inhibitors and even aspirin. But please remember, thrombolysis should not be done in this individual, right? In acute MI, you do a thrombolysis, but here thrombolysis is not required because you don't have any thrombus within the coronary artery, okay? But whenever you're giving beta blockers and AC inhibitors, let me tell you, the systolic blood pressure should be more than 90 millimeters of mercury, right? Systolic blood pressure should be more than 90 millimeters of mercury. But for suppose, if the individual is in a state of the cardiogenic shock, then you have to put the patient on IABP, that is intra-aortic balloon pump. Now, what does intra-aortic balloon pump do? This intra-aortic balloon pump will improve circulation to the myocardium during diastole, right, will improve circulation to the myocardium during diastole, and thereby it will increase the myocardial activity. So that is what is the function of your IABP, intra-aortic balloon pump. Now please remember, because the causative agent itself is a catecholamine excess, so drugs like norepinephrine, dopamine and dobutamine, right, norepinephrine, dopamine and dobutamine, they should not be given. Right, they should not be given. And in these individuals with the Takotsubo cardiomyopathy, sudden cardiac death can happen, right? Sudden cardiac death can happen. So that is about the treatment of the patient with the Takotsubo cardiomyopathy when the individual is in a state of cardiogenic shock. Now, so to summarize the Takotsubo cardiomyopathy, it is the disorder which occurs after a major catecholamine discharge secondary to a stressful event, and these individuals, they will have acute chest pain or shortness of breath. That will be the presenting feature. And this Takotsubo cardiomyopathy predominantly affects the postmenopausal women, and the presentation will be in the form of an acute anterior MI. But when you do a coronary angiogram, the coronaries will be absolutely normal. And when you do an imaging reveals apical left ventricular ballooning due to anteroapical stunning of the myocardium. So there will be ballooning of the apex of the heart. And most of the patients, they recover completely, right? Although there are complications similar to that of the myocardial infarction. So that is about your Takotsubo cardiomyopathy. So if you see this question here, myocardial stunning is seen in restrictive cardiomyopathy, cardiac tamponade, Takotsubo cardiomyopathy, pericardial shudder. So what will be the answer? The answer is the Takotsubo cardiomyopathy. Now you see one more question. Incorrect statement about broken heart syndrome. Catecholamine toxicity, ST segment elevation, apical ballooning, dobutamine for cardiogenic dysfunction. Let me tell you, catecholamine toxicity will definitely be there. ECG will show you ST segment elevation. 2D echo also will show you apical ballooning. But dobutamine for cardiogenic dysfunction should not be given in patients with the broken heart syndrome, right? Now, after having discussed about the Takotsubo cardiomyopathy, in Takotsubo cardiomyopathy, what did I tell you? Like there will be ST segment elevation within the ECG. But all your ST segment elevation in the ECG are not MI. There are many clinical scenarios where you have ST segment elevation in the ECG. That includes, see, these are all the conditions where you have ST segment elevation in the ECG. That is, the mnemonic is elevation, right? Mnemonic is elevation. E stands for electrolyte imbalances like hyperkalemia. L stands for left bundle branch block. Elevation E stands for early repolarization variant. V stands for ventricular aneurysm. T is your trauma, that is pericardiocentesis. I is injury like acute myocardial infarction. O stands for the Osborne wave seen in patients with hypothermia. N stands for non-occlusive spasm, that is Prinzmetal angina. So that is about the clinical scenarios where you have ST segment elevation within the ECG. Now, followed by that, let me just show you one clinical scenario and then we will wind up this session of the dilated cardiomyopathy. That is, a multiparous P3L3 young lady who delivered normally 3 weeks ago suddenly developed dyspnea, cardiac failure. She has no history of cardiac disease before or during pregnancy. She has tachycardia and peripheral edema, and hemoglobin is 9 grams per deciliter, and her echocardiogram has revealed ejection fraction of 35%. Which of the following is the most likely diagnosis? Acute MI, deep vein thrombosis with pulmonary embolism, amniotic fluid embolism, peripartum cardiomyopathy. So this is a classical clinical scenario of the peripartum cardiomyopathy. So why is that you are telling peripartum cardiomyopathy? You see, multiparous female, right? That is one of the risk factors for the development of peripartum cardiomyopathy. And no other demonstrable heart disease during or before the pregnancy. That is another important criteria for peripartum cardiomyopathy. And there should be a documented systolic dysfunction. If you see here, ejection fraction is 35%. So all these points are in favor of your peripartum cardiomyopathy. And she has developed that cardiac failure 3 weeks after delivering the baby. So in case of peripartum cardiomyopathy, the development of dilated cardiomyopathy can be up to 6 months postpartum, right? So this is a classical case of the peripartum cardiomyopathy, right? Now, why it cannot be DVT with pulmonary embolism? Because she is a postpartum female, right? See, in case of pulmonary embolism, dyspnea will be the clinical presentation, and ejection fraction 35% does not favor your pulmonary embolism. In pulmonary embolism, there will be right ventricular failure but not left ventricular failure. So that is the reason why your pulmonary embolism is ruled out. Okay. Now, after having discussed that, Dicrotic pulse is seen in hypertrophic obstructive cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy, and left ventricular failure. So, dicrotic pulse, it is seen in patients with the dilated cardiomyopathy, right? So, this completes the discussion of the theory aspect of dilated cardiomyopathy and as well as the MCQs related to your dilated cardiomyopathy. Thank you very much.